Good afternoon and welcome to Open Classroom. I'm Janet Gillo, Director of Professional Development for the Brown School, and so very happy to have you with us this afternoon. Throughout this webinar, our audience is muted, cameras and microphones are disabled. This program is being recorded, and we'd like to encourage you to join in the conversation through the chat feature, which is enabled. You can send messages to the panelists, your questions, or also offer comments that the panelists and all participants can see. So Open Classroom got started almost 7 months ago, 6.5 months ago, when the physical building of the Brown School had to close to visitors. And this has been our way of connecting community, sharing information. And I'm particularly excited about today's program because in some ways it represents circling back to where we started. Nancy Morrow-Howell, who's going to be with us today, moderating the conversation, was our very first Open Classroom. And we've come a long way in the 6.5 months since we were last together. So today I'm joined by my co-host, Cynthia Williams. She's the Assistant Dean for Community Partnerships at the Brown School, and she is going to be in the chat moderating your questions and taking note of your comments. Before we get started with today's program, I just want to note a couple of the things that we have coming up, because it does give you a sample of the work that's done at the Brown School and the way you can be involved. So on Monday at 6 p.m., we'll be hosting the final session of our Two Pandemics, One Election series of roundtables, and that topic is going to be on the future of justice. We're back 1 week from today, 12:30, on Tuesday for a workshop on virtual facilitation skills, something that we're all needing more of these days. And then at 3 o'clock in the afternoon next Tuesday, we have a presentation on HIV prevention in Uganda. So international healthcare, skill building, always something different at Open Classroom. And we're so happy that you're a part of today's conversation. Today, as I mentioned, Nancy Morrow-Howell is back with us. She is the Betty Bofinger Brown Distinguished Professor of Social Policy, an internationally known expert on gerontology and productive engagement during the senior years. She's the director of the Harvey Friedman Center on Aging. And she's here with a couple of her good friends to have a great conversation that we get to hear and then ultimately participate in. Nancy, thank you so much.
Thank you, Janet and Cynthia, my wonderful colleagues at the Brown School. I am honored to be moderating a discussion today with two experts from our Washington University community. They are dedicated to patient care, especially older patients, and they have been on the front lines of serving patients, particularly older patients, throughout the pandemic. They have volunteered to be here today to teach us about what they've learned about the disease and about how our healthcare system is responding. So let me introduce you to Dr. Lenise Cummings-Vaughn. She provides care to patients in outpatient, inpatient, and long-term care settings. She's the medical director of the Stay Healthy Clinic at WashU, which is at Barnes-Jewish actually, that is intended to decrease rehospitalizations. She sees patients at the Older Adult Assessment Clinic that's located in the CAM, and she is an attending for the inpatient geriatric consult service at Barnes-Jewish Hospital. She also is a medical director, associate medical director, and attending at a long-term care facility, Parc Provence, which is one of our state-of-the-art long-term care facilities for folks with cognitive impairment. She's actively involved in medical education, so we're delighted that she's here with us today. Also joining us is Dr. Chuck Crecelius. He's also a geriatrician, which is an internist. He's the medical director across many of the rehab and long-term care facilities associated with Del Mar Gardens that we're all familiar with. He's a clinical instructor of medicine and geriatrics at the med school. He is a full-time practicing clinician, and he has served as the president of some very distinguished organizations like the American Medical Directors Association and the Missouri Association of Long-Term Care Physicians. So you can see we have two amazing leaders in our community here to help us learn some things today about how we're doing with treating COVID and how our healthcare system is responding. So we're going to start today with a poll so that we can learn a little bit about your all's experience and where you've been. There's a lot of options on this poll, so notice that you have to scroll down the side to see them all. But the question is, how have you been impacted by this virus? Have you had it? Has someone in your family had it? Have you lost someone? So just take a minute and make sure you pull that all the way down to let us know how the current pandemic has affected your daily life. We're going to give you a minute. It's a long list. Janet, I'm assuming you're going to pop that up when you think it's done enough. Okay, let's take a quick look. So none of you have had the virus, but about a quarter of you had someone in your family with the virus. 11% of you have lost someone to the virus. Quarantine, 15%. Lost a job, 26%. You or someone in your family is frontline worker, half of you. Having to balance job and homeschooling, 11%. Had to postpone or cancel major life events. Only 7% of you indicated that you haven't had these effects. So that's a lot of impact of this disease. That was really kind of higher numbers than I thought. Chuck or Lenise, any comments about that poll before I throw out our first questions?
No, obviously we're talking to people who've been impacted by COVID, which it is a virus that's very impactful, much more than any other virus we've seen since 1902 pandemic.
Yeah. Thank you for sharing that. And we forgot to say, we have nothing, that's just for here. No other use of that information, and you can see it was anonymous. We have another poll coming up later. I wanted you to be assured of that. Okay, I'm going to ask Dr. Crecelius our first question. The virus has been around since the very first part of the year. What have we learned about that virus in these last months? And what have we learned about the virus and how we're treating it?
Coronavirus has been around a long time. It's not necessarily a new virus, but we've never had to study it in depth before. It was a minor annoyance, cold-like virus at worst. What's unique about this virus is its severe virulence. It really attacks cells, attacks bodies, and really causes damage, much more so than any of the virus we've seen in a long time. We've learned a lot about its modes of transmission, primarily like most respiratory viruses through coughing. We're learning that it's more airborne, perhaps. Talking, singing, yelling in confined spaces may transmit it more. It's not that hard to kill. Social distancing, wearing masks, usual viral precautions actually work pretty darn well. It's getting everybody to do it simultaneously for a long period of time. It's difficult. The knowledge of how to treat it, viruses are always very hard to treat. With HIV, it took forever to find effective treatments, and we're still in the infancy. The things we have to treat it are expensive and not really practical for everybody's use. Most of them are hospital-based. There's very little you can take to ward it off. There's a lot of proposed cocktails, and most of them are harmless outside of bleach. But there's vitamins, various concoctions of nutrients that people propose. I can't endorse or damn them because they haven't been adequately studied. So for the majority of people, it's avoidance, avoidance, avoidance is the treatment.
Mm-hmm. Lanice, following up on that, we're focusing on what have we learned about treating it. Dr. Crecelius indicated that you can only get some of those treatments in the hospital. What specific treatments are we talking about?
So first would be if a person was not getting enough oxygen into their lungs, supplying the blood takes the oxygen to the tissues. So if a person has a decrease in their blood oxygen level, then supplying oxygen through a mask or through a nasal cannula is something that, unless there's somebody else in the house who has oxygen, you would need to go to the hospital for. The second common treatment in the hospital would be steroids. I think we heard of this when the president received dexamethasone, which is a steroid treatment. The reason that they often will use some steroids is because part of the poor outcomes that they found earlier on in this crisis with COVID were from a person's own response to the virus. So steroids help to dampen your body's own response in the hopes that that decreased responsiveness wouldn't necessarily be harmful in fighting off the virus, but would be helpful in fighting off some of those bad outcomes that happen because people's bodies are kind of hyper stimulated and over responsive. And then there are these more specific, if a person is more dehydrated, not able to maintain their blood pressures or need fluids, if they have secondary infections, getting antibiotics, often through an IV. And then there are these drug cocktails that both Nancy and Dr. Crecelius talked about. Just most of them they're being studied, so you kind of have to be part of a study in order to get them. So you have to go to a hospital that's participating in a study. So those are the things that are available. Otherwise, it's mostly supportive treatment, which is mostly what we do with most viral illnesses. It's just that most viral illnesses don't affect more than just, usually we're talking about something affecting one organ, and the problem with COVID is it's not just the lungs, it affects other organs.
Let me come back to Chuck to ask about remdesivir. Where did that fit into Lanice's list of things we could get at the hospital?
Yeah, remdesivir basically can be viewed as an antiviral. If you've heard of Tamiflu for flu, it's somewhat similar to that, to work to modulate the viral response. That's a hospital-only medicine. I've had doctors ask, can I get it from Walgreens? No, you can't. It is in adequate supply right now to meet the needs of a hospital patient who's declining. There's just enough right now. The other medicine, Regeneron, that got a lot of attention, the monoclonal antibodies. We've used monoclonal antibodies for a lot of different reasons. When you see those ads for psoriasis, for rheumatoid arthritis, those are monoclonal antibodies. They've made an antibody just to that spike protein that binds to your cell, so it blocks the virus from binding. That takes time and effort to produce. It is expensive, at a minimum $2,000 per treatment. It may be effective. There's up to a 30% reduction in mortality. That may be age dependent. It may have to do with other factors that they're not really certain yet who it's the most effective in. A $2,000 treatment is a lot more expensive than a $19 vaccine. And so in the long run, it's a short-term solution, but a very expensive one. And it is not widely available. There's a real limited capacity for that medication at this time. Many hospitals don't have it, can't get it.
Lanice, you've started to answer this question, but I want to come back and walk us through if I decided I needed to go to an ER because I was having trouble breathing, or I was, afraid, I got afraid. What would when would somebody decide you need to come into the hospital, you need to get on oxygen, you need to get remdesivir, you need to go on a vent? Kind of walk us through how that might go for a typical patient who shows up at Barnes-Jewish emergency room.
Yeah, so all hospitals, including Barnes, are screening patients as well as if there any visitor that would come with them before they enter the emergency room. So on kind of getting to the front door, there would be a screen as to the reason the person's there and is it related to a concern for COVID or if they've had any exposure. And based on the answer to that, they would then be triaged to a certain place in order to receive further treatment or to wait for their evaluation. If they didn't come in with any concerns and might be in the general waiting room population, and end up in the emergency room and needing to be admitted, there's still a screening process that's performed. There's a new, I almost want to say like department in a way, a group of hospitalists that evaluate every patient that is being admitted and look at their risk factors for COVID, and will then decide whether or not they need to be tested for COVID before they go up to the floor. So that's regardless of whatever you say on entry to the emergency room, there's somebody else who will screen your chart to see whether or not you still need to be tested. Now, if you're presenting purely because you feel like you are at risk or of having COVID and you're having symptoms, they would go ahead and treat your symptoms, but also give you the test. And you would be in a room. Most of the emergency room, there are individual rooms. So that doesn't really change because there's no real shared rooms in the emergency room. But you would then be on an isolation precaution, which would mean that anybody who entered your room would have to use the proper protective equipment. And in that case, it would be, if you're not wearing a mask, the physician would either be wearing goggles or a face shield in addition to a regular surgical mask. There might be physicians who might wear the N95 mask also. And depending on risks for other things, they might also have on a gown. So that's something to consider. So anybody who has suspected COVID, whether they think they had it or evaluation of the chart indicates they might, these are the precautions that they will be under. And then the test usually comes back, within 3 to 12 hours, I think, for inpatients that they would get the test back, depending on when, you had the test. If you have it at 2 a.m, you might have to wait. But so those are the things that are happening right now.
Dr. Crecelius, when do we go to decide if you want to make any comments about anything more about treating the disease? I want to stick on this. I want to get to other aspects of the healthcare system. But anything you wanted to add about bringing people into the hospital?
It also depends on the site of service. When I work in a nursing home, I'm more likely to keep them there. I can provide supplemental oxygen and the like. It has brought a lot of advanced care planning conversations into effect. For some of my older people, frail with multiple diseases, they've decided to be treated in place at the nursing home no matter what the outcome. Intubation, being put on a ventilator, is not a good thing for people 85 and above with multiple diseases. The survival rate is low. So many people have made that decision that if I'm not going to be intubated, I don't have to be in a hospital. And that is the main reason for being in the hospital, besides getting certain medications. The primary treatment we provide there, we can't provide elsewhere, is intubation.
That's right.
You need to think twice about that. It's a very serious issue. Intubation mortality in anybody in the community, 80 and above, is as high as 50%. Intubation is very bad.
Did you say
80 years old and above? Right. It's about a 50% mortality rate. And that's all comers, nursing home, community, So it really is a matter of how robust you are. I hate to use age, but that's the markers we have.
Mhm.
Frailty is really the marker. Someone with multiple diseases, frail, bad diabetes, it's not good to be intubated. It's very
Yeah.
hard to get them off when the immune response gets that bad and floods the lung with fluids.
I want to come back to some of the things we're seeing in people changing, working on their advanced care planning. I have that for a question a little bit later. But let's stick a minute on how our healthcare system is doing. I think what scares us more than thinking about the disease is not having a place to go if we need help, right? With the overwhelmed hospital systems that we see on the news. Tell us what we've learned, and if you want to take a historical perspective, how is our hospital systems doing? Think locally, maybe nationally, and how are we doing in terms of protocol, equipment, capacity? I don't know whose turn it is to go first.
I can start.
Okay.
Because that's actually, Nancy, I left my office practice a month ago. I'm now working with BJC and the other hospital systems as in terms of transition of care.
Mm-hmm.
So I'm an overglorified hotel manager, moving people around from site to site. Right now, bed capacity is okay. We're about half of peak volumes where we were. It's still not great. It's mainly younger people now coming in the hospital, but their length of stay is a bit shorter, about 4 days. ICU capacity, ventilator capacity is okay. We're still all worried, is there going to be a second surge at some point in time? But for right now, that's okay. There's still some problems getting people out of the hospital with unique circumstances. We get homeless people that are in the hospital, and where do we put them?
Mm-hmm.
People that are in nursing homes, some of the nursing homes don't want to take them back. They're fearful of what they're going to spread it. They want tests on people who don't have COVID. Mm-hmm. And there's honestly not enough tests to test everybody leaving the hospital at this point in time. Right now, nursing homes have most of the test availability capacity because they're mandated to test. I'm tested every week because I walk in a nursing home, whether they have symptoms or not, to keep it out. So a 100-bed nursing home with 75 residents, 75 staff, are going to 175 tests every week. It adds up. So right now, capacity is okay, except we don't have all the tests we need. That is still a problem.
Lanice, can we get your perspective on that? How you're experiencing capacity, and do you have enough tests to use with who you want in your outpatient clinic, et cetera?
So right now, I don't feel like we have a lot of problems. Our nursing facility is using Barnes to do our testing. So that's been incredibly helpful that they've partnered with us to get those things done. But I do feel like it is still not completely straightforward for people out in the community when they need to get testing. So I've had a patient end up in the hospital who had no real COVID symptoms, but was thought to be at high risk. And so they tested her, she was positive. Her daughter works in a nursing home. And so her daughter called and asked me, when she needed to start her quarantine time, and if or when should she be tested. And these are not completely clear to most people, I would say. So I think that's a little bit problematic still, that people are still not clear about when they should start their quarantine, and probably from the time that their loved one was diagnosed, and then where they would get tested, because she asked because her mother was my patient, and I've had another patient who had to get tested to go back into a nursing facility. So their children asked if I could order their testing for them, and I said, well, I'm not your physician, so I can't. But I could see why this would, is confusing. Where would you go if you don't? You have to ask your primary physician, or if their job has some sort of a way to get them tested, since it's helpful for their job not to expose other people, or do they go through some sort of community way of getting it tested? So I would agree with Chuck that there are not enough tests for everybody who says that they just feel like they need to get tested. And it's also not very clear or easy to just go get tested. It's not that easy. So it's a little bit of a problem.
Yeah, I'd like to add to that too. The idea of quarantine when you've been exposed to somebody with COVID, it is 14-day quarantine. You cannot test yourself out of quarantine. You can test yourself every day until 2 weeks are up. You can still turn positive on day 14 and be negative the first 13 days.
That's right.
So there is a tendency to want tests when really it doesn't help. When you've been told to quarantine, don't ask for a test. It's not going to help.
Really? See, I don't get that. Will you tell us that one more time?
Right. The incubation period of the virus is 2 to 12 days. So after you're exposed, the virus may not be active in your body between 2 and 12 days. So you'll know by symptoms. There is some talk of getting a test at the end of the quarantine for statistical and other reasons. But basically, if you make it through 14 days after exposure and you have no symptoms, you either never had it or you had an asymptomatic test, asymptomatic case, and by quarantining, prevented transmission. The goal of COVID is be either asymptomatic or not pass it on.
That's right.
And I'd just like to mention right now, actually, St. Louis is at a tipping point. The reproductive rate is how many people you spread it to. It's always been above 1. We're now at 0.99. So we're just at a point where 100 people will transmit it to 99 people and it will slowly go away. So things are starting to look favorable. The positivity rate is going down in urban areas, but still going up in rural areas. So it is honestly, it's curious. It started off as an urban problem. It's now a rural problem in Missouri.
Yes.
Yeah. Okay, great. We're going to come back to some of those issues, but let me go on before we leave this topic of, I don't remember if it was Dr. Crecelius or Cummings-Vaughn that mentioned that somebody with underlying conditions. So we know older adults do worse because of complications. They're more likely to have an underlying condition. Tell us about what you're seeing with what those conditions, what conditions are sort of the most problematic. How does that complicate things? Just teach us about COVID plus underlying conditions that we see so many statistics about.
So individuals who have underlying pulmonary, so lung disease, heart disease, diabetes, or obese, these are people who are at higher risk of having poor outcomes. And this basically has to do with the immune response in the organs that are affected by the response and the infection. And so if a person already has pre-existing blood vessel disease or vascular disease, what they have found in terms of complications that happen with COVID is that this immune response that happens with the COVID infections increases kind of the cell death in the blood vessels, which can lead to blood clots. That's why I think earlier on in the disease, one of the most famous examples is that Broadway actor that had that long stay in the ICU. If you followed that at all, you know that you were probably wondering why he had so many. He was a healthy person, didn't have, but you could see if you did have any blood problems with any of your organs, it would be a problem. So one of the things that happened with him, he had blood clots and he ended up having to get an amputation. And so people who have diabetes or have other blood vessel disease are already at risk for having poor blood flow places, poor innovation, might be at risk for having these sort of things, bad complications from their disease process in their extremities or in their heart blood vessels. And so having that on top of COVID makes it worse. Lung disease, so if your lung function is compromised, yes, the main place that that the virus affects is your lung and causes lots of problems. So if you already have problems getting oxygen into your lungs, or if your lung tissue is already damaged or your airways already have damage, if you have more damage to the lung tissue, that can happen with COVID, or you have blood clots that form because of the infection that cause you not to be able to get air in, or blood that gets air, oxygen to take it to your organs, you could see why that would cause a problem. So these are the theories, at least for the most part, behind most of those things. I think it's similar what we're seeing in terms of people having the lingering symptoms. We're also very concerned about those same organ systems when people are having lingering problems for the most part. So hopefully that gives you some, I try to generalize it, but
Yeah.
those are some of the things.
Yeah. Chuck, would you like to add anything, especially what you think some of your patients that have had COVID a while ago and are still lingering? We've heard the term long haulers. What are you thinking about the longer term? What do we know yet, or what do we need to be figuring out?
Yeah, it's still a work in progress, especially the cognitive aspects. There's some concern about brain fog after COVID. What are the risk factors for that? Probably a lot of it are people who are immunocompromised and had a more severe case that had mild vascular damage to the brain, just as you can have vascular damage elsewhere. There's been some curiosity about worsening depression with COVID and without COVID. In my nursing home, honestly, we've had about as many people die. In fact, more people die of social isolation effects, severe depression, giving up, as we have had actual COVID. In our patients in the nurse home who have had COVID, I haven't seen a dramatic increase in dementia characteristics or cognitive decline, but I have seen a lot of post-viral fatigue, almost mono-like, 1 to 2 months to get to complete recuperation. And I think that's fairly common in younger people too. It takes quite a while to get over the symptoms.
Do you both think that this is unique to this particular virus? Or have you seen this kind of fatigue for 2 months and lingering confusion with other viruses? And I know you don't know, but I think that's the question in my mind. Is this going to be different than other viruses in those regards?
It actually is a diagnosis. Post-viral fatigue syndrome is an officially recognized diagnosis. We tend to think of mononucleosis.
Yeah.
Hepatitis virus, it causes that. It's not uncommon to find people who had hepatitis to have this sort of condition. So it's not unique, except that this was previously an impotent little harmless virus. It's the devastation it causes in terms of auto-activation of your own immune system is what's really unique about it.
Right. Could you tell us about that? That's the cytokine storm that we hear about? Is that the cytokine? Am I saying that right?
Right. Cytokines are basically chemicals your body makes to help fight inflammation. Inflammation is a good thing to a certain extent, just like a low-grade fever is good to help fight off infection. But when your body keeps producing it in unchecked quantities, it actually starts fighting against you. Somewhat analogous to rheumatoid arthritis, lupus, other autoimmune states. But unlike those diseases, this is all about your immune system for the most part.
Yes. So hence the steroids to try to control that response, right?
Exactly.
Yeah.
Given at the right time. Given too soon, you actually increase your chance of bad outcomes because you immunosuppress yourself.
Right.
So ideally, you want to give it right as you start needing oxygen. It's sort of the timing we use.
Okay. Okay, I'm going to move, watching our time, I got some more important questions here. We know that older adults are at higher risk for severe disease and death. We also know that people of color are in this community for a variety of reasons. How have you experienced the intersection of age and race and ethnicity in approaching this disease and family members and the healthcare system? I'm not sure who's going first. I think it might be Lanice's turn.
So for me, I would say what I've noticed are for my patients and their families, that depending on the circumstances of their families, whether there are a lot of people who are living in the same household, there's a lot of people who are who in these communities have been the frontline workers who never stopped working. They continued to work. They went out and worked. They had to work. They were part of the workforce that was needed. And then they went home or needed to care for their older adult family members. And this is where things get murky, because they weren't able to disengage or separate themselves from their older adults family member. And sometimes that then place their family members at higher risk. And I think this was somewhat problematic and partially, and only partially, explain some of the increased infection rate in African Americans especially, but in other minority communities. And then the higher incidence of pre-existing conditions in these populations also place then those people at higher risk of having poor outcomes. So if you get more exposure and then you're at more risk for higher outcomes, well, then the result obviously is that you're going to have more people with poor outcomes in these communities. And it's kind of like a horrible cycle of and very difficult. So if I have so many patients in my readmission clinic, if they or the person that lives in the house with them have not had the disease, they definitely have somebody in their family who either has been horribly ill, has been hospitalized, or has died. I have yet to have very many of patients who are in these categories that doesn't have something like that. And so there's an emotional and psychological impact of the disease on this population that I think we won't really fully find out about until all of this is done. And it's incredibly unfortunate. So I think it's a pretty complicated issue. And it really depends on, in different parts of the country, there are different things. We interviewed fellows this past week, and one of the fellows was from where I grew up, and she was talking about the hospital in that area. And most of the time, the majority of the people in the hospital were non-Hispanic, Caucasian, or white. And during this crisis, there's been large increases of African Americans and Hispanics, and mostly these were the people who are not just coming into the hospital, but then were quickly going to the ICU. And what does that mean when the population of the hospital changes like that? Mm-hmm. So I just think there's a lot to this that we will only know much later than now. It's going to be a process.
Chuck, would you like to add anything that you've seen in your transition work or in the nursing home setting?
Anything? I think this is sort of a culmination of some social determinant of health problems that are long-standing, as Lenise brought up. Mm-hmm. In my nursing homes, a large proportion of the workforce is African American. and they're doing their darndest to hold the job down, to not be exposed. Their exposure risk on a nursing home is much higher. They're very interested in wearing personal protective equipment. Initially, there wasn't any. And there were cases, it was awful to see aides coming down, nurses coming down with COVID because of lack of PPE. That's not the issue anymore. Now it's just a matter of fact that, as Lenise brought up, some have extended families. There's been other social injustices. When Black Lives Matter movement was at its peak, it's still obviously very important. But a lot of our staff were torn between, do I continue isolating myself to the fullest extent I can, or do I go out and protest? How can I support Black Lives Matter and be safe? And there were some hard ethical conversations there about what to do. I would tell you, all healthcare workers have been doing a heroic job. I'm not me, but the frontline staff. I get the luxury of going, seeing people, then going and isolating myself. I'm exposed to patients, but for the minimum time I can, then I go off and work on my computer. They're in there all day long. And God bless them for the pay they get and the circumstances they're under. They are so undervalued in our country. And that's all healthcare workers, home care, assisted living, hospital frontline workers.
Cynthia, I have a bunch more questions and we need to do another poll, but I want to make sure you think we're not missing, I want the audience to get some questions thrown in as well. Do you want to throw out one question from the audience?
Of course, Nancy. Molly said that she participated in a study to develop a saliva test. She is wondering if either of you know when the saliva test will be readily available instead of the nasal swab.
Yeah, there's some mild technical problems with that. It sounded really good, but it's not working out quite to be as sensitive and specific as they'd like. It's certainly no better than current tests. The current nasal swab is supposed to be done deeply, but if you do an anterior nasal swab just going about an inch, the results are about equal to saliva testing. And it's just not clear. The reagents for the spit test, as we call it, it's almost technically easier just to stick with what's out there. It sounded very appealing, but it just didn't work out quite as well.
Really? So we're not, I thought we were using it in some places.
They are. The NBA did.
Yes.
But the ability to ramp up the test has also been the problem. It came to the table late, and so they've not been able to ramp it up nearly as much as they'd like.
And they've been doing different things with those sort of tests. They do like pool tests, and then if there's anybody in the pool that's positive, then they do a nasopharyngeal test. So, I mean, in the end, people end up getting the nasopharyngeal test. It's just not the final test. Even if they do use it, it's not the final test. So it's problematic.
Yeah, that is disappointing.
Yes. You have no idea. Actually, Chuck knows if you're getting tested every single week.
Yeah.
I haven't done it that much. It's nothing that you want to get.
Yeah. Cindy, I was going to go on to the poll unless you feel like there's a good question you want to throw out.
Absolutely. Go to the poll, Nancy. That's great.
Okay. We want to do another poll with you all. You know, the topic of vaccines and who's going to take them anyway, and all of this. We want to know, get your all's opinion. What of these statements best applies to you? You will get the vaccine when it's approved through normal FDA procedures. You'll get the vaccine as soon as approved through emergency authorization. You won't get it under any circumstances, or you're not sure. How are you thinking about the vaccine? Okay, so 72% of you are saying when it's approved, you'll get it. 3% as soon as possible, 3% never get it, and not sure. Okay. Lanice and Chuck, do you think that represents the population, how people are thinking about the vaccine? Let's just talk about that now. What are your thoughts on the vaccine and how we're doing and who's going to take it, et cetera?
All right,
You wanna
I'm
go first?
obviously in favor of it. The state is actually working now on the distribution. So part of it is, can you get it to start with when it comes out? It will be available first to healthcare workers and to older population. Lanice and I are vectors. We should get it because we can infect a whole lot of people. So part of what I asked the audience was, how much of a risk factor for you? If your intention is to hole up in your house and not go out and have groceries delivered, you don't need the vaccine. Wait it out, that's fine. But I would try and have a sense of social obligation. The more risk you pose to society and your family, the more you should get that vaccine. There will be side effects, absolutely. Right now, the mortality rate above age of 80 is 20% with COVID. It's coming down some. It's about 1 to 2% when you're 20. But the real question is, what's your risk to society? And where's your moral obligation to get the vaccine to protect others? Nobody wants to be the first one to get it, and nobody should be the last one to get it. Everybody wants to be somewhere in the middle. But I think the country can rest assured that healthcare workers are going to be the guinea pigs. And then our nursing home population, older people, will be offered first. So if you're less than 65, you're not going to get it until we have some clinical experience going on. So hopefully more people will take it. We need to get to about 60 to 65% acceptance to hit herd immunity. Right now, it's supposedly 70%, but it
Well, we
appears
got that in this audience.
Yes, this audience will give the country herd immunity.
Lanice,
If in New York City, a lot of people have already had COVID, so they have less need to get the vaccine to hit herd immunity. We're average in Missouri.
Cindy, I saw a couple questions come in about this, but I couldn't. Can you help us with these questions about?
Yes, there's a question. How are the vaccine developers dealing with the fact that less African Americans are willing to sign up for the clinical trials, or the fact that some African Americans do not trust the vaccines and would probably not get it when released?
Well, I don't know what they're going to do about the latter. I'll speak to that. But the former, I think they're actively trying to recruit, individuals from, African Americans, Hispanic Americans, in order to increase representation for it's always a struggle. I think it's the same with any research trial, that it's often more difficult to recruit, and then the results of the tests then it's more difficult to generalize the results to that group. And so hopefully they've been able to get more. I don't think that they've released those numbers. I know the NIH, in order to get funding, you usually have to commit to at least have a plan of how you are going to have a recruitment in a diverse population. I don't know if that had to be part of the recruitment strategy in the government funding the vaccine development. I don't know, but I hope that it was, given that we do have a very diverse population in the United States, and that we want it to be, we want the vaccine to work in all these populations. In terms of the trust issue, this is an ongoing problem, and I think it really comes down to, I think the government and the healthcare industry is going to have to start putting out ads and working with community programs and churches in order to increase knowledge, give education to people about the risk that is posed by not getting the vaccines. This is kind of what is usually done when people are not getting vaccines. And I'm a little bit sad that I haven't seen that start, because the truth is you have to do quite a bit of work in order to get people to take the step. I know in my clinic, I can't tell you how many times I call it my stump speech, that I tell people the same thing and tell them about, you know, the importance of getting the vaccine. And I know it's been documented that they've turned it down before, but you have to keep asking people and talking to them and telling them why it's important and how it's important. And I'll add on to what Chuck said in terms of what he says to people in terms of obligation. I told a patient's son just last week, I said, well, if in the moment have been admitted to the hospital and they tell you that they're probably going to have to take you to the ICU and intubate you, and if it would go through your head, like if you would get a flash that said, oh, I wish I really had gone ahead and got that vaccine, well, I suggest you just go ahead and get it, because there is nothing worse than regret.
Mhm.
And who wants to have regret and be intubated? These are two horrible things. So I would say just, you know, these are the things I try to give people foresight, that, you know, I know this is what you're thinking, but I'm not going to lead you wrong. They have to have somebody who they trust tell them that they're taking a risk that they probably don't want to take.
Mhm. Chuck, do you want to add anything? And Cindy, I think there's another question about vaccine. If you want to, let me see if Chuck wants to add anything before we throw that
Yeah.
one out.
The question, I saw it too, was about getting the vaccine in relationship to having had COVID.
Right.
Right now, the thinking is when you had COVID, you're auto-immunized for 90 days. So we'll see what happens when the vaccine comes out, but most likely it's going to say get the vaccine 90 days after infection. You probably won't have to get the vaccine for 90 days. They may not recommend it, frankly, given a relative shortage and desire to get people immunized or protected.
Mhm.
It
After
appears,
90 days, they're probably going to say get the vaccine.
and part B of that question is, do you think a booster would be required?
Probably.
Probably.
Not certain yet.
Mhm.
And unfortunately, this may be a yearly vaccine for a while.
Mhm.
There are mutations occurring in the virus. They haven't been substantial enough to affect our therapies or really make it a brand new strain, but that's certainly a possibility. We may have a virus here we have to start vaccinating every year against, or every 6 months, somewhere in that order. One of the vaccines, Moderna's, appears to have much longer lasting and higher immunity rates, but it may come at the cost of side effects.
Mhm.
Some of the others are probably going to be booster shots.
Mhm.
It's 6 of one, half does the other. When you have a really strong vaccine, typically the incidence of adverse effect rates is such that it makes no difference if you get the shot twice or once. It all equals out.
Mhm.
And Mark Twain said it best: there's lies, there's damn lies, and there's statistics, but you are more likely to die from COVID than you are the vaccine. Just cut and dry. There's no doubt about that. Nobody wants to get Guillain-Barré and be paralyzed from the vaccine. But the person that happens to ought to be viewed as a hero. They risk themselves. And there is a compensation fund for vaccines. In case you weren't aware, in order to get people vaccinated, if you get an adverse effect, there's a vaccination fund you apply to and they take care of you. That's how we got all childhood vaccinations, through polio, all the others. It's a guaranteed, we'll take care of you if you have an adverse effect.
There's another question, Nancy, that I think is pertinent. It asks, what potential side effects might come with the vaccine?
Yeah, you keep talking about side effects. What are they?
I don't think they haven't released the side effect profile, but I would say it's probably something like the side effect profile of all the vaccines that we have so far. So injection site pain, bleeding, the chance of having some sort of immune reaction, having a fever. These are some of the common, side effects of present vaccinations, but I think they're still in development, so we really don't know if there's something specific. Everything else about COVID has been special, so who knows? Maybe there will be a different side effect, but I don't know. What do you
Yeah.
think, Chuck?
Yes.
Cindy, I haven't, Chuck, were you going to talk, but you sounded.
Yeah, I was just going to say the worst one is a neurologic side effect, the swine flu vaccine type affair. And they're watching very carefully for that. The one trial that was stopped temporarily found no association between the patient's symptoms and the vaccination.
Oh, that's right.
So,
Okay.
and you got 6 vaccines now in phase 3 trial. So I'm feeling pretty good about a minor incidence of serious side effects. When you've got between 6 vaccines, probably 20,000 people enrolled and no association yet, that's pretty good. Post-marketing studies, vaccination in a million, you probably are going to find some rare side effects, serious side effects.
We are getting close on time. Cindy, I have one more question, but I want to make sure, do you have another question?
There is a last question from Emily. She says, post-viral fatigue, depression, and cognitive decline. These sound like particularly difficult problems for the older adults who are fortunate enough to survive COVID. Do we know who is at risk for those outcomes or the best ways to intervene?
Yeah, people with poor immune systems to start with are probably more at risk for post-viral fatigue syndrome. And depression may have as much to do with premorbid tendency towards depression or mood disturbance. There's a lot of reactive depression. Any of us can get depressed under the right circumstance. In nurse homes, when you haven't seen your loved one for 6 months except through a window, yeah, it's normal to be a little depressed. Reopening nurse homes right now is critically important. We're trying to find more ways to have visitation. Our Zoom visit, this is therapeutic for me to talk to people. I can actually see people and talk to them. That's why I'm chattering on. So I think everybody needs to work on maintaining as normal lifestyle as possible, make phone calls. Seeing people's face without a mask on is wonderful for healthcare workers. You can't read people's face with a mask on. So there will be a new normal. Some of this may persist for a while. We may be a little more cautious. I was one of those people that would smirk every now and then at an Oriental traveler wearing a face mask a year ago. I don't smirk anymore.
Yeah, right, yeah.
I wish we had done that ourselves. I thought they were being overly cautious. Maybe that's going to be our new normal.
Right. I need to figure out a way to wrap this up. I don't want to, but I'm going to ask our experts to, what's the best takeaway, lessons learned going forward that we've learned or can keep that's the best of this thing for all of us? Lanice?
Oh, I think, for me, professionally and personally, I feel like I've learned that I need to be patient with myself and others, that we are often not in control of very many things. I think what we've learned is that we're not in control of many things, but the things we are in control of, we need to take seriously. I think there is a certain level of importance of understanding science and the implication it has for our health. And I think there's a baseline understanding that everyone should have. And so it's really upsetting or disturbing that misinterpretation of information can cause people problems. And I think we all should try to educate ourselves and others. I think it's important for us to make sure that everybody has as much information as possible.
Chuck?
And I'd echo those sentiments. I would note an ounce of prevention is worth a pound of cure. So wear your mask when you're out, socially distance, you use alcohol on your hands appropriately. But on the other hand, part of prevention is maintaining your mental health. Find other ways to socialize with people. Join a book club, read, clean your house. Do something. Do not sit there and please don't watch the news programs all the time. I have nothing against newscasters except they've made this an entertainment industry that'll drive you crazy. Go
Mhm.
to CDC website, CMS website, WashU, Mayo Clinic, Cleveland Clinic. If you want to get accurate information, check with authorities and get accurate information.
Yeah.
And find a way to live life. I keep having Que Sera, Sera going off in my brain by Doris Day.
Thank you, Dr. Crecelius and Dr. Cummings-Vaughn. You have educated us more. So we will educate ourselves more thanks to you and thanks to your service.
You're welcome.
Thank you all. And thanks,
Yeah.
Janet and Cynthia, for a great hour together.
Thank you. Everyone, enjoy your afternoon.
Thank you.